Good evening. Thank you all for joining us. My name is Andre Mansour. I'm an internal medicine physician at Oregon Health and Science University in Portland, Oregon. And I'm joined with Joseph Nugent here, who's a medical student at OHSU. And the topic of our presentation today is the jugular venous pulse. This presentation is called The Art and Science of the Jugular Venous Pulse. And we hope you enjoy it. Just a reminder that this presentation is video heavy, and your best experience will be on a device that can handle videos like a computer. So if you're calling from a phone right now and you can switch over to a computer, I would recommend that you do so. Joe put together the videos that you will see in this video that I think really make this presentation unique. So you won't want to miss those. And this work that we've done on this is part of a larger project called Physical Diagnosis PDX, which is a website that we'll be launching soon. And we've been working on it with our colleagues, Pete Sullivan and Ashita Sharma, for a number of years. And we hope to launch soon. And if you guys like what you see in this presentation, you will love the website. So let's get started here. And we're gonna start with a quote from prominent heart failure physician, Carl Lear, who has written extensively on the importance of physical examination. So regarding the neck veins, he writes, quote, "The inability to properly assess the pressure level and wave contour of the internal jugular veins should encourage the cardiologist interested in heart failure to either learn and develop skill in this component of the physical examination or move to another area of cardiovascular medicine." And we love this quote. We couldn't agree with it more. And while Dr. Lear was addressing cardiologists, we think that this quote is even more applicable to the general internal medicine clinician. Our approach to evaluating the jugular venous pulse includes three separate but related components. Number one, identification of the jugular venous pulse. Then there's quantitative assessment and qualitative assessment. And we're going to touch on all three of these components in some detail. And then at the end of the presentation, we're going to kind of bring it together with a multimedia quiz that we'll go through together to kind of reinforce the ideas that we learned about today. And these three components are create a natural break in the presentation. And you guys can feel free to ask questions using the chat box. And probably what I'll do is pause at the end of each of those components, and then we can address questions before moving on to the next section. So section one is identification of the jugular venous pulse. This is the single most important of the three components, simply because without it, components 2 and 3 cannot even be attempted. And you may hear from trainees and other colleagues that, the jugular venous pulse wasn't visible in a patient for X or Y reason, typically because of a large neck or the presence of a beard. In our experience, the jugular venous pulse is visible in the vast majority of patients. You just have to know where to look and how to find it. So where should you look for the jugular venous pulse? The go-to place and the most ideal place that you should go to first, it's a right internal jugular vein. It's ideal because of its direct route into the right atrium. If you can't find it on the right, then you should go to the left next. You should look at the left internal jugular vein. And by the way, when we talk about looking at the internal jugular veins, we're not actually visualizing the vessels themselves. We're visualizing the movement of the skin that overlies those vessels. If you can't find it on the right, you can't find it on the left, the external jugular veins is kind of your third option that you should go to. And unlike the internal jugular veins, the external is visible. It's a visible vessel in the skin, much like the veins in the back of your hand are visible. Those are the first three locations you should go to. And there are other places though. If you can't find it in the neck, there are other places to look, and we'll get to that later in the presentation. This data comes from a 1973 study that essentially looked at how well right atrial pressure correlated with pressure in the right internal jugular vein, the left internal jugular vein, and the external jugular veins. And you can see those three graphs from left to right. They plotted right atrial pressure on the x-axis, and they simultaneously measured pressure in those vessels and plotted that pressure on the y-axis. And this data demonstrates two things for me. One is that you can see the right IJ correlates really well with right atrial pressure. It's pretty much a linear line. The other thing that this data demonstrates is that the left IJ and the EJ are nearly as reliable as the right IJ. So I present this to show you guys that you should feel comfortable using any of these vessels. So now that we know where to look, let's talk about how you find the jugular venous pulse. The first thing that you want to do, and the most important thing, is position the patient. Half the time I walk into a patient's room, they are slouched in bed and they've got, multiple pillows behind their neck is flexed forward. And if I try to move the angle of the patient's bed, it just moves their neck. That is not ideal. What I do is I flatten the bed and I sort of help the patient to slide all the way up to the top of the bed so that their head is near the top edge of it. And now when I move the back of the bed, the neck and the torso are moving as one unit. You want the neck and the torso to be in the same plane. The other thing that can happen is that the sternocleidomastoid muscles can sort of obstruct your view of the neck. So you want to make sure that they are nice and relaxed. And the way you do that is you either add or remove pillows. I find that the majority of the time, removing a pillow allows the neck to relax. Starting at about 30 to 45 degrees for most patients makes sense. And so once you've positioned the patient, their neck and their torso are in the same plane, their neck is nice and relaxed. Now what you want to do is you want to observe the neck. And it may seem silly to kind of, include that as one of the steps here, but it's so important because the tendency is to observe the neck from a perpendicular perspective. But if you do that, you're going to miss subtle movement. That's why this is so important to emphasize the observation, because you want to observe from a tangential perspective. That will allow you to pick up subtle movement in the neck. So imagine you're staring at a wall. If you're looking directly at the wall, you're looking at it from a perpendicular perspective. Now imagine you walk up to the wall and you put your right ear against the wall and your eyes are looking down the wall. That's a tangential perspective, and that's how you want to look at the neck. That's how you want to observe it. So step one is patient positioning. Step two is observing the neck from a tangential perspective. Now your next task is to locate movement in the neck. And the traditional window for viewing the jugular venous pulse is between the patient's clavicle and the angle of their jaw. If the pulse is below the clavicle, you're not going to see it. If the pulse is above the angle of the jaw, you may see it, but it's not ideal for evaluation. So what you want to do is you want to manipulate the patient's angle in order to bring the waveform or the movement within kind of the middle of the neck if you can. Once you've done that, once you've positioned the patient, you're observing from a tangential perspective, and you've located movement in the neck, you're not done. The most important task is next. Now you have to decide, is this movement that I'm seeing arterial or venous? And there are a slew of strategies for determining whether the movement that you're seeing is arterial or venous. The first thing is the waveform itself. It can be very revealing. An arterial pulse is a single peak that is quick and sharp. The venous waveform, on the other hand, tends to be double, and it's undulating in nature, meaning that it's got a soft rise and fall. The most striking feature of the arterial pulse is the outward movement. You're going to see an outward movement, and obviously what goes out must come back in, but it does so gradually and subtly, and it's hardly noticeable. It's a passive retraction back to baseline. The venous pulse, on the other hand, is the exact opposite. What you're going to notice, what will catch your eye about the venous waveform, are the inward movements. It's, instead of being passive, these are active movements, kind of a sucking in motion. It's an active movement inward. It's the X and Y troughs that will catch your eye in the venous waveform. And that, I put an asterisk there because that is, to me, is the most useful of all of these strategies. If I'm looking at a waveform and I see inward movement, I'm done. I know that's a venous waveform. The other thing that can be helpful is how much area of neck is involved. The arterial pulse tends to be pinpoint, involving a small area of the neck. The venous pulse, on the other hand, tends to be diffuse, involving a larger area of the neck. The arterial pulse does not change with patient position or angle, respiratory cycle, or abdominal pressure. And the reason it doesn't change is because the arterial pulse, the reason you see the carotid and feel it where you do, and the reason you see and feel the radial pulse where you do, is because that's where the vessel courses closest to the skin. So that's an anatomical phenomenon, and that's not going to change whether the patient's breathing in or out, or whether they're at 45 degrees or 90 degrees. That's an anatomical thing. So the arterial pulse is unaffected by those things. The venous pulse, on the other hand, will be affected by these things. So as the patient's angle changes, so will the location of the venous pulse. So if we have a patient at 45 degrees and you see the jugular venous pulse in the middle of the neck, if that patient is then reclined into a more supine position, that waveform will climb up the neck. It will move up the neck anatomically. If instead you put the patient in a more upright position, the opposite will happen, and that waveform will move down the neck. Similarly, the jugular venous pulse is also affected by the respiratory cycle. So normally when we take a breath in, we decrease our intrathoracic pressure, and that will cause the column of blood to move down and suck into the heart. And obviously as that moves down, you're going to see that in the neck, and the pressure will also go down. Sometimes the opposite happens, where you get a paradoxical rise in JVP with inspiration called Kussmaul sign. We'll get into that more later. But either way, if you see respiratory variation, if you're looking at movement in the neck and you're trying to decide, is this arterial or venous, and it moves depending on the respiratory cycle, you can be fairly confident that that's a venous pulsation. The venous pulse will also move up the neck with abdominal pressure. And then lastly, the arterial pulse is palpable typically, whereas the venous pulse is almost always non-palpable with a few exceptions, which we'll get into. So let's all imagine that we're at the patient's bedside, and we're going to go through those steps that we talked about. So the patient is positioned, the neck and the torso are in the same plane, the neck is nice and relaxed, and now we're viewing the neck from a tangential perspective. Okay, and if you'll remember, our next job after that is to look for movement in the neck. And we can all see that there's movement in the top third of the neck here. And if I were to describe that movement, I would say that what I see is a single outward pulsation that is quick and sharp. And it takes up a relatively small area of the neck. It's rather pinpoint. You almost like you want to put your finger right there. And if you did, you would feel a pulse. These are all the characteristics of an arterial pulse. And Joe has annotated these videos for us. And you can see here in this annotated video, if you follow that cursor along the tracing, you can line it up with the movement that you're seeing in the neck. So you'll see the arterial pulse, boom, 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 boom. It's a single outward pulsation. I don't really see it aggressively coming back in. It's very passive. I want you guys to look at this video and look at this movement, and I want you to compare it with the movement that we're going to see in this next video. Here we see a double peak. And what catches your eye about the movement that we're seeing in this video? What catches my eye are the inward movements, the troughs. I see down, 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 or in, 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 in. I hardly see the outward waves. I really just see the inward movement. And look how diffuse this movement is. It's stretching from near the clavicle all the way up. You can see movement all the way up here. It involves a large area of the neck. It's diffuse. These are all of the features of a venous pulsation. So I want you guys to remember these two videos. And it's a nice contrast between the arterial pulse and the venous pulse. So let's move forward here. And we talked about abdominojugular reflex, or at least we mentioned it. Now, this is a physical exam maneuver where you put firm pressure on the patient's abdomen, and then you observe the effect on the jugular venous pulse. And this maneuver has several applications, but the one that I want to focus on right now is in its ability to help you identify venous versus arterial. An arterial pulse, again, is not going to move with abdominal pressure. So if I see movement in the neck and I want to decide, is that movement venous or arterial, I can put pressure on the abdomen. And if I see it move up the neck, I know it's venous, or I'm more confident that it's venous. The arterial pulse will not move. So we can observe here, you can see that there's movement near that cursor. And with abdominal pressure applied right here, you can see that waveform climb up the neck, that pulsation climb up the neck. So we're confident that that is a jugular venous pulse. Play it one more time here. There it goes, all the way up to the jaw. So now I'm confident that what I'm seeing there is the jugular venous pulse. Now, we talked about the right internal jugular vein being your go-to spot. That's the first spot you should go to look to evaluate the jugular venous pulse, again, because of its direct route down into the right atrium. But sometimes the right internal jugular vein is not available. Why? Because the patient may have a clot in the right IJ. Maybe they have a catheter there. And in some cases, it's just not explained. Sometimes you just don't see it well on the right. So you should then move to the left. And this video is simply here to demonstrate jugular venous pulse on the left side of the neck. You can absolutely see and appreciate the jugular venous pulse on the left. If neither of the IJs are available, what was our third go-to? That was the external jugular. And here you can see it really well illustrated. It's this vein right here that you could absolutely, you could actually see the vessel itself in the skin of the neck, much like you can see the veins in the back of your hand. Now, this video is not filmed from the most, attractive vantage point, right? Because we talked about the perpendicular perspective being not ideal. And that's where this is being filmed. Must have been one of the early videos that I took where I didn't quite appreciate how important it was to film and to view from the tangential perspective. If you saw this from the tangential, you would see a much richer, you'd have a much richer experience. The movement would be more obvious. But what's nice about this video is that you have an arterial pulse right next to a venous pulse, so you can actually appreciate the differences between them. Now, this artery is likely aneurysmal, and so it's not totally normal, and it probably is taking up a little bit more area of the neck than an arterial pulse would normally involve. But nonetheless, all the other features of this pulse is classic for arterial. There's a single outward pulsation that is quick and sharp, and you don't really see an aggressive inward movement. It sort of just gradually retracts back. The aggressive part of this waveform and what you notice and what catches your eye is that outward movement. That's classic for an arterial pulse. Compare that with the venous pulse just next to it, and you'll notice that the venous pulse is much more diffuse. It stretches from up here all the way down here. There's a lot of neck involved in the movement. The inward movements are most dominant, and it's sort of an undulating or soft rise and fall. So this is a nice example of an arterial pulse just next to the venous pulse. If you can't find the jugular venous pulse in either the right IJ or the left IJ or the EJ, don't stop there. Many clinicians would stop there and say the jugular venous pulse was not visualized. But if you do that, you're going to get burned, because sometimes, in some cases, the central venous pressure is so high that even when the patient is in the upright position, that waveform is not going to drop down into the neck. And so you have to look higher before giving up and saying, well, I could not see the jugular venous pulse. Look higher. And you want to look in the areas that you want to look in the periauricular area, you want to look in the temple area, and you want to look in the forehead, because often the pulse is there. And here's a great example of the jugular venous pulse. You see that unmistakable inward movement of the venous pulse in the periauricular area. If you don't see it in the periauricular area, look higher. Here it is, the unmistakable inward collapsing movement of the venous pulse right here in the patient's temple. I hope you guys can all appreciate that. And if you don't see it next to the ear, and you don't see it in the temple, look even higher. Sometimes it's in the forehead. And this is, again, the unmistakable collapsing movement of a venous waveform in this patient's forehead. Her central venous pressure was quite high. And in fact, all of these last three patients that we've looked at, all of the clinicians that evaluated the patient beforehand had said that the jugular venous pulse was not appreciable. And it's because they failed to look higher than the neck. So I just want to emphasize that, if you don't see it in the neck, you should look higher. That's actually all we have for the identification component of the talk. And here's one of those natural breaks in the talk where we can kind of review some questions and maybe try to answer those before moving on to quantitative assessment. So let me see if I can look at some of these questions here. So, Okay, someone asked, Andy asked, what do we mean by the neck and torso in the same plane? And that just means, Andy, that the neck and the torso are at the same angle as one another. The neck is not overly flexed and it's not overly extended. You know, you can imagine a situation where a patient has three pillows behind their neck and their chin is sort of tilted forward toward their chest. That's not an ideal situation to evaluate the jugular venous pulse. You want to get that neck at the same angle of the torso, or as the torso. Let's see here. Is there any special consideration in trying to find an external jugular vein? I don't know if I've ever seen it. You know, Ariel, that's a great question. And some people have visible external jugular veins and others do not. It's sort of similar to the veins on the dorsum of the hand. Sometimes you can see them pretty clearly in someone, and other patients, you don't see them at all. And I would say the same is true of the EJ. And so, you know, I would say that maybe the minority of patients have visible external jugular veins. And then Zavin, who you should look at all of his jugular venous pulse videos. He's recommended Ariel to look at one of his videos, and you absolutely should. Zavin has a great collection of videos that really demonstrate the jugular venous pulse very well. Let's see. Nate is asking, do you stand on the left side of the bed when viewing the right IJ? Yes, I do actually, Nate. So I always, examine patients on the right side, and there's no rhyme or reason to that other than to develop a system and do everything the same way every time. And when you do that, you're less likely to miss something. So when I stand on the patient's right, I kind of tilt my head across their chest and sort of evaluate the right side of the neck from that tangential perspective. I sort of lean over and I'm looking kind of at the right IJ. That's exactly right. Okay, so Mohit has asked why the jugular venous pulse has the aggressive inward movements, and we're going to discuss that in section 3, which is the qualitative assessment. I'm sure there are other great questions here, but just for the sake of time, let's move on to the second component here, which is quantitative assessment. So quantitative assessment is otherwise known as jugular venous pressure. Okay, so now we've changed from jugular venous pulse to jugular venous pressure, or JVP. When a clinician reports a JVP of 8 centimeters of water or 16 centimeters of water, they are providing a quantitative evaluation. And this is probably the most frequently applied component of the 3 components used on a day-to-day basis. So we should begin by asking the question, what are we measuring? Well, we're measuring right atrial pressure. And in order to interpret what a JVP means, we have to understand what is normal right atrial pressure. And when we're measuring it with a right heart cath in millimeters of mercury, it's less than 6. When we're measuring it via examination in centimeters of water, it's less than 8. So why do we care about right atrial pressure? Why are we measuring it? Well, first, knowing right atrial pressure can provide a diagnosis. When that patient comes in, that undifferentiated patient comes in with dyspnea or shortness of breath, the JVP exam is absolutely critical. And at best, it can provide you a diagnosis. At worst, it will narrow your differential diagnosis. And beyond its diagnostic utility, we often use JVP to establish and follow a patient's volume status, who might be admitted to the hospital with decompensated heart failure. So it's incredibly important. So now that we know what we're measuring and why we're measuring it, the next question is, how do we measure it? So what we want to measure is the height of the column of blood above the middle of the right atrium. If we can figure out that, and that's the pressure in centimeters of water, if we can figure out how high that meniscus is above the right atrium, that will tell us the pressure. The problem is the right atrium sits in the middle of the chest and we can't see it. So we have to use landmarks that we can see to extrapolate to the center of the right atrium. If we know that a certain landmark is X centimeters above the right atrium, and we know where the top of that jugular venous pulse is relative to that landmark, well, it's simple math to figure out how high that column is above the middle of the right atrium. The angle of Louis is one such landmark. So that classic number, 5 centimeters above the right atrium, that holds true. They did a great study. It's in our references section where they used CT imaging, and they determined that actually that 5 centimeters That really only holds true when a patient's in the supine position up to about 30 degrees. Beyond 30 degrees, the angle of Louis becomes more like 8 to 10 centimeters above the middle of the right atrium. Another landmark that can be used is the clavicle, but only in the upright position where it is about 12 to 16 centimeters above the middle of the right atrium. Now, textbooks will often show how you can determine how high that meniscus is above the angle of Louis. And they'll show this by having a vertical ruler and another straight edge, sort of estimating where the height of that JVP is. Now, no one does this in real life. What I would recommend that you do is measure the width of your hand. Okay, so I know my hand, the width of my hand is 8 centimeters. And so what I do is I put the sort of the pinky side of my hand, or the hypothenar side of my hand, down on the angle of Louis. And so now my thumb is pointed straight up at the ceiling, and the palm of my hand is facing the patient's neck. Now I use this hand as the ruler, and I will estimate, where do I see that the top of that column? Is it right at the top of my hand? And let's imagine the patient's in the supine position. So the angle of Louis is 5 centimeters above the right atrium. Well, I would say my hand is 8 centimeters. And if I see that meniscus at the top of my hand, I would say that's 8 plus 5 is 13 centimeters of water. If I see that column in the middle of my hand, I might say, okay, it's probably 4 centimeters above the angle of Louis, in which case it's 4 plus 5 is 9 centimeters of water. Sometimes it's higher than my hand. And in that situation, I might put my left hand on top of my right hand. Now I have both hands as a ruler, and let's say the meniscus is a hand and a half above the angle of Louis. Well, I would say that's 12 centimeters plus 5 is 17 centimeters of water. And that's the way that, clinicians really measure the JVP at the bedside. So let's look at an example here of a patient with elevated central venous pressure. And there's movement here right at the angle of the jaw. And to be honest with you, if I were in this situation, if I truly wanted to know the height of this column of blood, I would actually sit this patient up higher, because we don't know if the column is, maybe it's as high as here. So to know that the top is truly where I think it is, I would want to sit this patient up and allow that column to drop more to maybe the top or the middle part of the neck here. And then I would truly know that that's the top of the meniscus. But let's say, for the sake of this example, that this is the top right here where we see movement at the angle of the jaw. So let's imagine that this patient is at 45 degrees and she's a slender woman. So we're going to say, you'll remember that the angle of Louis is 8 to 10 centimeters above the right atrium at 45 degrees. So we're going to say that, hers is 8. And let's say that the top of this waveform here is 10 centimeters above the angle of Louis in this position. Well, we would say that it's 10 plus 8 is 18 centimeters of water. And that's how you would report your quantitative assessment. Now, if you see indentations in a patient's forehead, you should immediately think about long-standing central venous pressure. So this patient is a nice example of indentations in the forehead, these sort of divots there in the forehead. And here is the same patient in a more reclined position. And you can see that those veins are now engorged with blood, indicative of elevated central venous pressure. So if you see these divots in the forehead, you should immediately think about that. Now, there's one last place to look. If you can't find the jugular venous pulse in the patient's neck, you've looked in the right, you've looked at the left, you've looked at the EJs, you can't find it anywhere there. You've looked at the periauricular area, the temple, the forehead, and you can't find it. There is one last place to look, and that's the hand. So we're gonna allow this video to restart here. But what you want to do is you want to start with the hands at the patient's side. And what you'll find, if the patient has engorged veins on the dorsum of their hand, like this patient does, what you'll then do is you'll lift the hand up above the chest, and you will find that, you'll drain those veins of the blood. So here we go, we're lifting it up, and there the veins go. So can we all see that those veins are entirely flat? So now what you're gonna wanna do is slowly lower the hand down until you find that moment where the veins start to fill with blood again. And it's starting to happen right there. Can you see that? That's the moment where those veins start to fill, and that's the central venous pressure. So if you can figure out, see what I did there with my left hand, you extrapolate across. And if you can figure out how high that that point is above the angle of Louis, you can extrapolate to the right atrium. So this patient's in the supine position, and let's say that the hand begins to fill again 18 centimeters above the angle of Louis. Well, you would simply take 18 and you'd add 5 to it, and you'd say that the central venous pressure here, or the right atrial pressure, is 23 centimeters of water. So there it is. So I'm going to take my left hand, I'm going to extrapolate across to the angle of Louis, and I'm going to figure out how high that is above the angle of Louis. That concludes the quantitative assessment part of this talk. So now would be a good time to pause and answer questions before we move on to the third and final component, which is the qualitative assessment. So let's go back here and see if we can answer some questions that came up. I see Moises has joined us. Welcome, my friend. Let's see, in patients with COPD hyperinflation, with the right atrial distance increase relative to the angle of Louis? Absolutely, Patrick. Yep. And that's, it's one of those things in medicine where, we have these rules of thumb. We say 5, we say 8 to 10, we say 12 to 16. But in reality, every patient's different. Body habitus changes, from COPD and obesity. And so, yes, absolutely, the number is not going to be the same for every person. And you sort of just kind of take that into account on an individual basis. Ty asks, will a patient with an upper extremity AV fistula for dialysis have an artificially elevated JVP due to the abnormally high returning volume through that fistula? If so, would it affect the ipsilateral IJ more than the contralateral IJ? Similarly, would that cause a sucking effect if using hand veins to estimate? That's a great question, Ty. I would say, yeah, if you have a high output state, you can absolutely see potentially maybe a falsely elevated central venous pressure. I'm not sure whether it would affect the right more than the left, so I'm not sure the answer to your question there. And then lastly, would that cause a sucking effect if using hand veins to estimate? I'm not sure quite what you mean by that question, but feel free to rephrase it, and at the next break, I'd be happy to try to answer it. But those are tough questions. Can you repeat the distance to the right atrium from the angle of Louis according to the position of the patient? Arturo, I'm not sure what you mean by repeat the distance. But again, just keep in mind that these are all rules of thumb. And in reality, if I say that the jugular venous pulse is 14 centimeters of water, that's no different than 15 or 16 centimeters of water. I mean, this is not an exact science. We want to know, is this elevated, normal, or low in reality? And so, if it's off by a centimeter or two because, you've used a wrong correction factor for your landmark, then that's not, in the grand scheme of things, it's not really going to change how you approach that patient. These are all great questions. And I think Zavin may have a better understanding of that last question than I did, and is answering it in the chat. So please feel free to look there. Let's move on to section 3, which is qualitative assessment. This is a more sophisticated sort of endeavor where you're actually looking at the waveform itself. And there is so much that can be learned about the heart by assessing the waveform beyond simply measuring right atrial pressure. I'll illustrate that point by asking a rhetorical question. What is Mobitz 1 heart block? I think that we would all answer this question electrocardiographically. We would say that Mobitz 1 is PR prolongation before a dropped QRS complex. And you would be right in your description. But what if I told you that Wenckebach described Mobitz 1 heart block in 1893, which was several years before the EKG was available to him? So how did he do it? Well, this is a talk on jugular venous pulse, and if you guessed that he used the neck veins, you'd be absolutely right. The question is, how did he use them? And hopefully, at the end of this section, it will become clear how he used the jugular venous pulse to describe Mobitz 1 heart block. In order to understand abnormalities of the jugular venous waveform, you have to understand the normal waveform. You have to have an intimate understanding of each component of the normal waveform and what cardiac events cause each component of the normal waveform. So let's go through them. Let's start with the A wave. So the A wave is caused by right atrial contraction. So obviously, as the atrium contracts, that's going to create an increase in pressure, and you're going to see that as a positive deflection in the waveform. So that's a positive outward wave. That's the A wave. And when does right atrial contraction occur? It occurs at the end of diastole when it's trying to squeeze that last bit of blood into the ventricle. And the reason I like to orient myself early on to the cardiac cycle is because then I can sort of go in order, and I can sort of more easily recall the events that cause each component of the waveform. So right now we're in late diastole, where the atrium contracts and causes a positive pressure wave in the waveform. So right after late diastole, now we're in early systole. And what's happening in early systole? Well, in early systole, you have isovolumetric contraction. That's where the pressure builds up in the ventricle, and that is going to cause the tricuspid valve to slam shut. And when the tricuspid valve slams shut, it sort of bulges into the right atrium, and it creates a little bit of a pressure blip, a positive pressure deflection, and that's the C wave. Now, it's important to note that the C wave is not visible at the bedside. Okay, so after early systole, now we're in the middle of systole. So what happens right after isovolumetric contraction? Well, now you have actual mechanical contraction. And when the ventricle contracts, it sort of kind of contorts and squeezes and twists down when it contracts. And when that happens, that is going to cause a mechanical, it's going to pull down on the right atrial floor as it's twisting in contraction. And what else is happening during the middle of systole? Well, the atrium has just contracted to squeeze out the last bit of blood into the ventricle, and now it has to relax. And so atrial relaxation occurs. And obviously, as the atrium relaxes, that's going to cause the pressure to go down. So the combination of mechanical ventricular contraction, which pulls the floor of the right atrium down, and that in turn is going to cause that column of blood to pull down, and right atrial relaxation contribute to the X descent. That happens in the middle of systole. Now we're in late systole. Now the atrium has just relaxed. And why did it relax? Well, it relaxed because it wants to fill again with blood so that this whole thing can start back over again. And so in late systole, the right atrium is filling with blood. And obviously, as volume fills the right atrium, volume implies pressure. So as the filling occurs, the pressure is going to go up, and that's going to create the V wave. Now we're done with systole. Now we're back in diastole. So what's the first thing to happen in diastole? Early diastole, you've got the tricuspid valve that's going to spring open, and now you have passive ventricular filling. So all that blood that just filled the right atrium is now going to flow into the right ventricle passively, and that causes obviously the pressure to go down in the right atrium because it's losing blood and losing volume into the right ventricle, and that causes the Y descent. So in order to understand what's going on with the waveform, we have to understand each component of the waveform and what cardiac events causes each component of the waveform. So let's revisit this video from earlier in the talk. Now, a lot of people will tell you that, oh, you can't see the components of the waveform at the bedside. That is absolutely not true. And this is a perfect example of that. So here we can see, and Joe has done this where he has overlaid the tracing over the videos, and you can follow the cursor along so you can see each component of the waveform. And I think we can all appreciate for sure the two descents. So there's an X and Y, X, Y, X, Y. And again, it's the inward troughs that really catch your attention. It's really, the outward movements don't really catch your attention very much. They're not very obvious. Sort of opposite of the arterial pulse. And I'll play this at quarter speed. So there's A, X, V, Y, A, X, V, Y, A, X, V, Y. So we can really appreciate each component of the waveform. And again, I would emphasize that it's the inward movements that really catch your eye here and that are obvious. So let's show another video where there's this neat trick that you can do to sort of illustrate the waves a little bit more. And Joe has annotated this video for us as well. So here's A, X, V, Y. So you can absolutely appreciate each component of the waveform at the bedside. Now, one important thing to emphasize here is that you really want to know where you are in the cardiac cycle. So if you're evaluating the neck veins and the waveform itself, you want to know, is that the A wave? Is it the V wave? Is it the X descent or the Y descent? And what I do is you will always see me looking at the neck veins while I'm either palpating the pulse or while I'm listening to the heart, because I'm trying to find a frame of reference so that I can figure out, what am I looking at in this waveform? Is that the A, the V, is the X, or the Y? And so one cardiac event can really serve as a great frame of reference, and that's S1. We know that S1 is caused by closure of the tricuspid valve. And we know that S1 is going to occur at the same time as the peripheral pulse. So what else happens? What happens in the waveform as a result of tricuspid valve closure? Well, we've just discussed that, and that's a C wave. And the C wave occurs right in the middle of the X descent. Again, you're not going to see the C wave at the bedside, but it happens in the middle of the X descent. So we know that the X descent should occur at the same time as S1 and at the same time as the peripheral pulse. So I'm often listening and feeling while I'm looking at the neck veins. And if I'm interested in a particular trough, if I see, oh, there's this inward movement that's catching my attention, I want to know, is that the X or the Y? I will listen to the heart, I will palpate the pulse. And if it's occurring, if that trough is occurring at the same time as S1 or the peripheral pulse, that's the X descent. If that descent is discordant with the pulse, I know it's the Y. And that's how you orient yourself to what you're seeing in the neck veins. I cannot overemphasize this point. Knowing where you are in the cardiac cycle when you're examining any patient is so critical. It cannot be overstated. Let's revisit this video from earlier in the talk where we see a venous waveform next to an arterial pulse. And so what I would say is that in this venous pulse, I can see two troughs, but there is one trough, there's one descent that is dominant, right there, there. So now I want you guys to think, answer a question, is that the X descent or the Y descent? And how could you tell? Well, as we just talked about, if you were at the bedside, if you had the advantage of being at the bedside here, you could listen to the heart while you looked at that dominant trough. And if you were hearing S1 at the same time that you saw that dominant trough, it would be the X. Or if you were palpating the pulse and it happened at the same time, that would be the X. If it was discordant, it would be the Y descent, that dominant descent that we're seeing there. Now, in this case, we have the advantage of seeing an arterial pulse just next to it. And again, the pulse should occur at the same time as the X descent. And what we can see here is that pulse, if you look at it, that pulse is occurring at exactly the same time as that dominant descent. So that is indeed the X descent that you're seeing there, the dominant one. There are two descents. The dominant one is the X. And again, I can't overemphasize how, this presentation, these videos are well done, and they really illustrate the concepts that we're talking about here. But there's no substitution for being at the bedside, because you have the advantage of being able to listen to the heart and feel the pulse while you're evaluating these waveforms. So now let's move on to discussing some abnormalities of the waveform. So the top tracing here is the normal jugular venous waveform, which you'll remember from a few slides ago. And the tracing below it is abnormal. So what's abnormal about this waveform? Well, we don't have an A wave. We've lost our A wave. There is no A wave here. And the other thing is that, so we have no A wave. We don't have much of an X descent. Remember, in the normal waveform, the X is more dominant than the Y. And in this case, the X is tiny. So thinking back to our normal waveform, what causes the A wave and what causes the X descent, at least in part? Well, the A wave occurs as a result of atrial contraction, and the X descent occurs in part because of atrial relaxation. So what condition is there? No coordinated atrial contraction and no, atrial relaxation. Well, that's atrial fibrillation. And you'll also notice that this waveform will occur in an irregular pattern. So at the bedside, what you'll see here is you'll just basically see a Y descent. You don't really appreciate the X or the C or the V, you really just see a Y. And, because it's happening in an irregular pattern, sometimes there are two pulses that are close together like these two, and you might confuse that for an X and a Y, but in reality, it's a Y followed by another Y. And so that's what you'll see at the bedside, is really just a Y descent here. Okay, so keep that in mind. Let's move on to the next one. And I see that there's some questions being asked, and we'll pause at the end of this section to answer those questions. So let's move on to the next waveform. And what do we see here? Well, we see a larger than normal A wave. Okay, the A wave is larger than normal. And again, we've got to go back. Well, what causes the A wave? In the normal tracing, well, the A wave is caused by right atrial contraction. So what would cause right atrial contraction to create more than normal pressure in the right atrium? Well, that's if there's some resistance to right ventricular filling. And what would cause that? Well, tricuspid stenosis would cause that. Also, increased end diastolic pressure in the RV would cause that from things like pulmonary hypertension. The atrium has to squeeze against higher pressure, and when it does so, it creates higher pressure in itself, and that causes a giant A wave. Importantly, the giant A wave occurs with every beat. So keep that in mind. So what you're going to see in the neck here, recall earlier, the normal jugular venous pulse, you don't really appreciate the outward movements very well. It's really just the X and the Y that you see very well and very clearly. If you see an outward pulsation, if that catches your eye, that should immediately suggest to you that something is not quite normal about this jugular venous pulse or this waveform. And that's exactly what you would see with a giant A wave. You would see an outward pulsation, and that would catch your eye, and then you would know something's not quite right with this waveform. Why am I seeing an outward pulse? And if you see that outward pulse, it's going to be followed by two troughs. Okay, that's going to be an important concept that will come up later. So the giant A wave is going to be followed by the X and the Y. You have preservation of your X and Y descent. Let's move on to the next abnormality, which is a cannon A wave. So here you have an even larger than giant A wave. So what's worse than contracting against a stenotic tricuspid valve? Well, it's contracting against a totally closed tricuspid valve. And obviously, if that occurred with every beat, it would not be compatible with life. So this is in a situation where you have atrioventricular dissociation, where the ventricles are going at their own rhythm and the atria are going at their own rhythm. And every once in a while, the atrium is going to contract against a totally closed tricuspid valve. And obviously that's going to create a big pressure wave in the right atrium. And that really looks like a ripple up the neck. It's a shock-like wave up the neck. And again, this is typically intermittent. It can sometimes occur with every beat when there's retrograde atrial activation from a supraventricular tachycardia, let's say a junctional rhythm. You can see it with every beat. Don't worry about that so much. Actually, there's a great video that was circulating on Twitter in the last couple of days of somebody showing that. It's called the frog sign, and it's cannon A waves with every beat. But that's not the norm. Usually it's intermittent. And that's helpful for differentiating cannon A waves from giant A waves. As a cannon A wave is typically intermittent. And it will be one peak. You will not see two troughs following the cannon A wave. When it is intermittent, you will see the normal waveform in between the cannon A's. So the key here is that it's intermittent. The next abnormality that we should talk about is what's called a CV fusion wave, also known as Lancisi's sign. And this is a physical finding of severe tricuspid regurgitation. So what's happened to our waveform here? Well, we've lost our X descent. That's gone away. And what has replaced it is the CV fusion wave. Okay, you get your A, and then what would normally be an X, you don't get, and you get the CV fusion wave with a big Y descent. So what's happening what causes the X descent? Well, that's occurring in the middle of ventricular systole. And again, the right atrium is trying to relax during that time. And instead, with tricuspid regurgitation, you've got this gigantic bolus of blood that's now going retrograde back into the right atrium in the exact moment it's trying to relax. So you lose your X descent and you get this large wave, this bolus of blood that goes backwards into the right atrium, and it causes this giant CV fusion wave. And this is followed by one trough. So that's an important point. So if you look back at the A wave, remember that the giant A wave is still going to have an X and a Y that follows it. The tricuspid regurg and the CV fusion wave will have one descent that follows it. And the timing is also different. Again, remember, we're going to be at the bedside normally here. And if we see this large outward wave and we're just trying to decide, is this a CV fusion wave or is this a giant A wave? You can also time it. And the CV fusion wave is going to occur right with the peripheral pulse. And if you listen to the heart at the same time, you might hear a holosystolic murmur at the left lower sternal border that goes right along with it. Okay, so one One peak, one trough. Now, what's happening in this waveform? What's abnormal here? Well, our Y descent is different than normal. Our Y descent is sharp and deep. So what is this called? This is called Friedreich's sign. And why would this happen? This is a physical finding of restrictive cardiomyopathy and constrictive pericarditis. So why would this happen? If you think about constrictive pericarditis, you have this unyielding pericardium, and the ventricle, once it starts to fill, it's going to run into the pericardium eventually, and it's going to stop filling. So what that means is that all filling has to happen very early in diastole. Okay, so you get this sharp and deep Y descent because all that filling has to happen early in diastole before the ventricle runs into that unyielding pericardium. The next abnormality that we should talk about is the W sign. So here you have, instead of just a sharp and deep Y descent, you also have a sharp and deep X descent. And you can trace this out and it looks like a W. And this is more specific for constrictive pericarditis than Friedreich's sign. And why some patients with constriction only develop a sharp and deep Y descent and others develop both a sharp X and Y is not totally clear, but some subset of patients with constriction do develop an X and Y known as the W sign. The last tracing before we get to the quiz is what you see here is a paradoxical rise in jugular venous pressure with inspiration. So recall earlier we talked about how the jugular venous pressure is going to go down with inspiration. When it goes up with inspiration, it's called Kussmaul's sign. And normally when you take a breath in, you're decreasing your intrathoracic pressure, so you're pulling that column of blood down into the heart. But if the RV is not compliant for any reason, whether it's RV failure or tricuspid stenosis or constriction or restriction, remember, you're also pulling blood from the legs and elsewhere back to the heart. So if the heart can't accept that increase in blood flow, well, that blood has nowhere else to go but fill the neck veins. And so that's why you get a rise in pressure, in jugular venous pressure with inspiration in these conditions. So that is the end of that section of the qualitative assessment. Now we're going to watch some videos next, but let's pause there and see if there are any questions. And by the way, these questions are going to make this talk run a little bit past 6 o'clock, but I think that's okay. Okay, it may be a little tough to sort out what the questions are here, but let's move on. I think you guys are ready to look at some videos. And so what we're going to do next is we're going to watch some videos, and these are all neck veins, and we're going to try to figure out what is the qualitative abnormality that we're seeing here in the neck. And before we start, I just want to say a few things. First, assume that the movement you're seeing in these videos is venous. Okay, that's first. Second, this will be challenging. And it's mostly, again, because you don't have the advantage of being at the bedside, where you can sort of use those strategies that we talked about before, where you might feel the pulse or listen to the heart at the same time that you're looking at the neck veins. But when you watch these videos, try to think to yourself, what catches my eye? Is it an outward peak or is it an inward descent? If it's an outward peak, that automatically suggests something is abnormal, because remember, the normal jugular venous waveform, you don't really see the peaks very well. You just see the trough. So if you see a peak, think to yourself, that's abnormal. And then, you could probably narrow it down to either a Cannon A wave or a giant A wave or a CV fusion wave. If it's happening with every beat, that's less likely to be a Cannon A wave. So it's probably either a giant A or a CV fusion wave. And then you want to look, okay, how many troughs do I see after that? Is it one or two, monophasic or biphasic? If there are two troughs, then that's probably a giant A wave that you're seeing. If there's one single trough, it's probably CV fusion. Also pay attention to whether there's respiratory variation in these videos. Also pay attention to whether the pulse is irregular. All those things will help you. The last thing I'll mention is that there are some repeats. So just because we see something once doesn't mean we won't see it again. So let's, having said that, look at our first video. So I'll give you guys a moment to kind of watch this video. And again, assume this is venous and kind of think to yourself, what catches my eye here? So I'm going to talk through this. So what I see, and that's absolutely right. This is CV fusion, absolutely. So what I see is a single outward peak followed by a single trough. And remember, that outward movement is not really that noticeable normally in the jugular venous waveform. So I know there's something abnormal here. Is it a giant A? Is it a cannon A? Is it CV fusion? Well, it's probably not a cannon A wave because, again, that's more like a shock or a ripple sort of a wave. And that's usually intermittent. So now I'm down to this, is this a giant A wave or CV fusion? And I only see one trough following that wave. If this were a giant A wave, you would see two troughs. And we're seeing one. So this is indeed CV fusion or Lancisi sign. And here Joe has annotated the video for us so we can watch it. You see a little bit of an A, and then you see the CV fusion, followed by a single wide descent. And this is a gentleman with severe tricuspid regurgitation from dilated cardiomyopathy. So let's move on to the next video here. So I'll give you guys a few moments. So watch to see whether you see any respiratory variation. And again, this is, you're absolutely right. This is Kussmaul's sign. Nice. So let's provide the annotation here that Joe's created for us. So you can see the meniscus there in the middle of the neck, and the patient's about to take a breath in. And when she does, you see that rise up to the, look at that, goes all the way up to the angle of the jaw. That EJ, look at that, it looks like a worm in the neck. That is filled with blood. So that is a positive Kussmaul sign, absolutely. And when she takes a breath out, it goes back down. Now, the other thing is this video happens to show two signs. So you have Kussmaul sign, and what else do you notice about this? I think someone's saying it's constriction. So look at the X and Y descents. They are fairly obvious and sharp and deep. So look at that XY, 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 especially when she takes a breath in. These are sharp and deep X and Y descents. So she has both Kussmaul sign and the W sign. And this is a patient with constrictive pericarditis. Let's move to the next video. So what catches your eye here? Is it a peak or is it a trough? What catches my eye about this video is a trough. So see it right there, 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 there. There's one obvious trough. And if I see that, then I'm thinking, is that the X or the Y? And if I'm at the bedside, again, I would feel the pulse, I would listen to the heart at the same time I'm looking at this. We don't have the advantage of being at the bedside, but I will tell you that that S1 is discordant with this trough, or the pulse is discordant with this trough. So which trough is it? That would be the Y. That would be the Y descent. So let's show the annotated video here. And so what you see is you see a little bit of an X and then the Y. Boom. So X, Y, X, Y. So this is a case of Friedrich's sign. So this is a sharp and deep Y descent. And this is a patient with constrictive pericarditis. Actually, he had subacute constriction, which is an entity that I was not familiar with before this case. I thought all constriction was chronic and irreversible. And it turns out that in some cases you get edema and inflammation of the pericardium that causes constrictive physiology for several weeks before it resolves and goes away. And that's exactly what happened in this case. He had subacute constriction that got better over time. So this is an exaggerated Y descent or Friedrich's sign. Let's go to the next video here. So again, think to yourself, what catches my eye about this waveform? Is it a peak or a trough? And to me, I'm seeing a peak very clearly. There's a peak, absolutely, Antonio. There is a peak that catches my eye. And now I'm narrowing this down to, okay, if I see a peak, that's automatically abnormal. I don't usually see that in the normal jugular venous waveform. So is this a giant A? Is it a cannon A? Or is it CV fusion? And Antonio has already gotten the right answer. This is a giant A wave. And the reason we know that is because we see two troughs that follow this giant outward pulsation. There's preservation of the X and Y troughs which indicates that this is a giant A wave, not a CV fusion wave. So let's kind of go over this. So here we go. So A X V Y, A X V Y, A X V Y. Do you guys all appreciate that? So this patient had methamphetamine use, and as a result of that, had developed pulmonary hypertension. She had severe pulmonary hypertension, and that led to giant A waves. All right, let's watch this video and see what we think. And remember, there are some repeats. Anybody have any ideas what we're seeing here? Absolutely, yep, Kussmaul's. A bunch of you guys are getting this right. And so let's show the annotated video. So here you see the movement in the middle of the neck where that cursor is, and he takes a breath in, and there it goes all the way up to the angle of the jaw. Classic case of Kussmaul's. What else do you notice on this patient's skin right below the A wave of our logo down here? What is this? Anybody know? Yep, absolutely. You guys are absolutely right. That is a tattoo marker, radiation tattoo marker. And this individual had Hodgkin's lymphoma when he was a teenager and had radiation to the chest. And it's just amazing. Such a great illustration of the hypotheses that you could develop. You know, could he have, just from exam, could he have radiation induced tricuspid stenosis? And is that the cause of Kussmaul's sign? Could he have constrictive pericarditis from the radiation? Is that the cause? It's just amazing the hypotheses that you could generate just from examining a patient. And in this case, he had constrictive pericarditis. Okay, let's move to this video, one of my favorites. So what are we seeing here? Yep, absolutely, Adam's right. So this is Lancisi's sign. And so we see a single waveform and a single trough. And what's amazing about this video is you can see the A just before, look at that. A, CV, A, CV. There's a little stutter before the CV, and that's the A wave. A, CV, A, CV. So this individual had severe TR. And we're almost done here. I realize that we're just a few minutes past 6 o'clock, but we're almost finished with the presentation. So stay with us here. So what do you guys notice in this case? And actually, this is a tough one because it's difficult to tell where the patient is breathing in and out. So I'm going to give you guys the annotated version here. So look at that. So when she breathes out, you can see it all the way up at the angle of her jaw. And when she breathes in, it goes down below the clavicle. So Zavin had a great example of this a few months ago on his Twitter page. This should make you think about, so this is normal, right? This is the normal pattern. The JVP goes down with inspiration, but it's usually not this marked. I mean, this is a difference of 10, 12 centimeters. And you should immediately think about lung disease in a case like this. And indeed, this person had COPD. Now, the reason this is important is because sometimes you could get fooled into thinking that the CVP is elevated. So you might see it up there at the jaw and think, wow, this person has markedly elevated central venous pressure, and you might give them diuretic when in fact they could be euvolemic or hypovolemic. I made that mistake, early on in my career, and I've since learned that when I see this marked respiratory variation, that is lung disease. Let's move on to the next video here. So the obvious movement that we're seeing here is inward, right? So it's a down, down, and then pretty much that's all we're seeing. We're just seeing one descent, and it's occurring in an irregular pattern. And this is what you'd see with atrial fibrillation. One single trough. And again, I made this point earlier, when you have two beats that are close in proximity, it may look like an XY combination, but it's really just a YY. So this is classic veins of someone with atrial fibrillation. I think we just have maybe a couple more here. Okay, so what do we have here? So what do you notice? What do you notice here? This is another example. Yep, you guys got it. Adam's got it. This is Kussmaul's sign. So when she breathes in, look at how those neck veins engorge near the angle of her jaw. Look at that. So she breathes in and there they go. So classic example of Kussmaul's sign. And this patient had constrictive pericarditis as well. Okay, so let's see. So sometimes observation can, can get you in trouble, Zavin. So let's look at this next video. So what do we see here? In the interest of time, I'm just going to talk through this one. This is another case of Lancisi's sign, and this individual had his facial vein involved, which is really remarkable, and it gives us a remarkable video here. So we see a single outward wave followed by a single trough. That is CV followed by Y every time. And this patient had severe TR. Let's look at this video. This one's tough, but if someone can get this, I'd be very impressed. What stands out to you when you're looking at this? Is it a peak or a trough? Yep, Antonio is right again. This is a giant A wave, and you can really appreciate that with the annotated version here. I'll slow it down to quarter speed. So you see, so there it is, A, followed by an X, a V, and a Y. A, X, V, Y, A, X, V, Y. And the A is emphasized because we really see that outward pulsation, which is atypical for a normal jugular venous waveform. It's totally conspicuous. I agree, Ariel. And this is a patient with tricuspid stenosis. And he had giant A waves as a result of that. Okay, one more. Let's see, two more videos here. So what do we see here? Yep, you guys are right. This is another example of Kussmaul's sign. Okay, let's go to our last video. So this is another tough one. Tell me what you guys see. I'm waiting for Antonio to get this right, as per usual. So what I see here, so you guys are totally right that there is an outward wave that catches your eye. So CV fusion's on the differential, giant A is on the differential, and Cannon A wave is on the differential. It's a shock-like ripple up the neck, and it's occurring intermittently. Let me put the annotation over the top here. So here we see, there it is right there. There it is. Then there's a normal, and the normal I'm seeing down here. So there's the giant A, or the Cannon A, then there's normal, then there's a Cannon A. There it is again, normal. There it is, couple normals, normal, and then boom, there it is. So this is intermittent, and this is a patient with complete heart block, as Ashley has correctly guessed. All right, so now we're ready for the final quiz question. Maximus from the movie Gladiator, who's not supposed to be alive at this point, but clearly we can see movement in the neck. Question is this movement arterial or venous? And how do you know? Absolutely, it's venous, and it's venous because exactly, it's diffuse. It extends all the way along the neck, and it's an inward movement that really catches your eye. So this is classic venous waveform. So let's circle back to Wenckebach before we conclude. So how did he describe Mobitz 1 without the benefit of an EKG? Well, just think to yourself, what is the equivalent of PR, the PR in the neck? So the P wave on an EKG is atrial depolarization / contraction. And what is that in the neck? Well, that's the A wave. Okay, and then what is the R wave on the EKG? That is ventricular depolarization and contraction. And what is that in the jugular venous waveform? That's the X descent. So what he saw, he observed AX prolongation in the jugular venous waveform before an arterial pulse was dropped. And that's how he described Mobitz 1. And it's just a very powerful example of how the neck veins can tell you so much about what's going on in the heart. that concludes our talk. For more, if you guys enjoyed this, stay tuned for our website. So again, Joe, Pete Sullivan, Ishita Sharma, we've all been working on this for a number of years, and hopefully we'll launch this here in the next couple of weeks. Also on Twitter, we show these things. Instagram and Facebook, a couple of outstanding medical students, Katie Berry and Mayana Fearborn, are some students who run those sites, and they're doing an outstanding job sort of demonstrating. It's usually about physical findings that they'll show on the Instagram page or Facebook. And it's a great way to kind of learn this stuff. And so that concludes our talk. Here are the references. We hope you guys enjoyed this. And please, leave feedback. We're always trying to make this better. And by the way, this is the first time we've done this. I think that hopefully it went well. You guys enjoyed it, and we can do this again and maybe even explore other topics in physical diagnosis. And I'll stick around actually to answer questions if you guys have any. Okay, so let me scroll back here and see if we can get some questions. So Zaman had a comment here. Someone earlier had asked how to differentiate a Canon A from an arterial impulse. And let's see, it's shock-like. I agree, Zavin. Shock-like travels up the neck, just like that last video showed. Let's see. I'm glad you guys enjoyed the talk. Let's see. How long did it take you to make a qualitative assessment of the JVP, or how long does it take you? Antonio, I think that's going to vary with experience, and and sometimes it's difficult. They're not all textbook videos like we showed in this presentation, and sometimes it's really taking minutes at the bedside to listen while you're looking and trying to line up what you're seeing in the neck with what you're hearing in the heart or feeling in the pulse to figure out what's abnormal about this waveform, and what component is catching my eye. Is it an outward component or an inward? And if it's an inward, I want to know, is that the X or the Y? If it's an outward, I want to know, is that CV fusion or is it a giant A wave? And you just got to take the time necessary to line it up with the cardiac cycle and decide, is that an A or is it a CV fusion? So I would say that, as you go on, really sometimes you can just, as you're more experienced, and it sounds like you are, really just looking at the neck veins and looking at that movement, you can sort of nail the diagnosis right away. CV fusion, I can sort of just walk into a room and look at that neck, and if I see that classic wave, I can tell you that this person has severe TR without much more than a second or two. Can you identify JVP in normal people for practice purposes? Can we identify? Absolutely. So actually the normal jugular venous waveform that you saw in this presentation is a perfectly healthy young woman who is a PA at OHSU, the hospital that I work at, and she is completely healthy, and that was her JVP. So you can absolutely see that in normal people. Let's see if there's other questions here. All right. You're very welcome, Ajay. I'm glad you enjoyed it. And, stay tuned for the website. We're going to have material that is very similar to this, including heart sounds, other physical findings. We're going to move beyond cardiology. We're going to get into endocrine, rheum, ID, all of the disciplines. Does JVP analysis have better sensitivity specificity for anything compared to POCUS? I would say that I think just like the stethoscope, POCUS is a tool that we have to learn to use. And, I would say that I found myself Not learning. I use POCUS absolutely for procedures. I won't do a thoracentesis or paracentesis without first looking with ultrasound. But I found that if you can hone your physical exam skills, especially with a cardiac exam, I often don't find myself at the bedside sort of thinking, if I had an ultrasound, I would know what's going on here. Um, I found that, just the exam itself, you can become really, really good at this, and you can figure out what's going on in the heart without the use of an ultrasound. That's not to say that I discourage it. In fact, I think using the ultrasound can be really helpful to hone your skills. So one thing that I'll do is if I have a patient and they have an echocardiogram, I'll use that to help kind of calibrate my exam. If I know that they have severe AR based on their echo, well, I'm going to be listening for that decrescendo diastolic murmur over Erb's point. I'm going to be looking for Quincke's pulse. I'm going to be looking for, Corrigan's pulse in the neck. So if I have an ultrasound, I'll use it. And I don't want to discourage that in any way, but I think that the exam is something that you can absolutely learn and become very proficient in, to where you don't find yourself reaching for an ultrasound. I'm glad you found it worthwhile to stay up till 1 a.m., Adam. It's nice to hear from you. I'm glad you joined us. Um, and yes, thank you for mentioning that. We are indebted to the patients who also believe in medical education and let us use their images for that purpose. This presentation, this website would not exist without those patients, and so we are incredibly grateful to them for that. I'm glad you thought so. 2 a.m. I don't know if it was worth staying up till 2 a.m. for. Uh, how can I get the recording? Joe's gonna have to answer that. He is the computer guy. I know nothing about computers or recordings. Would the recording be available somewhere? Again, that's a question for Joe.
Yeah, the
5:30
recording will be
a.m. in India.
available once Zoom servers process it. The recording will be sent out to everyone that registered for this, so sometime in the next few days.
That's great. I would not have woken up at 5:30 a.m. to see this lecture, Ajay. I would still be asleep. Yeah, we'll do another lecture at another point in time, and we may even repeat this lecture with maybe different videos, perhaps, because we have quite a repository of that's certainly not the only Lancisi sign I've seen, or giant A wave. So we've got other videos that we can share with you guys. At what point in your career did you learn the importance of measuring the JVP? I'm a med student, and in most of my lectures, no one has ever taught it this way or emphasized its importance. I see that all the time, Arturo. People like to downplay the importance of the jugular venous pulse. And, I was lucky that I had a mentor and a colleague, Pete Sullivan, again, who's one of our partners on this project, Physical Diagnosis PDX, who really ignited my interest in the exam. And I'll tell you a story, and it has to do with one of those patients that we saw earlier. It wasn't the same patient, but it was a similar situation where we were evaluating the neck veins, and we noticed that the neck veins were up. And what Pete noticed, and he asked the patient, he said, "When did you get radiation therapy?" And the patient looked kind of surprised and said, "Well, I had it, 20 years ago. How did you know?" And it was because Pete observed the tattoo markers on the patient's chest, and he put together the tattoo markers with the elevated jugular venous pulse and the abnormal waveform to conclude that this person might have constrictive pericarditis. And he put it all together based on the exam. And when I saw that, it really kind of blew me away and ignited my interest in the exam. And ever since that time, Pete and I will examine patients together, and it's nice to have someone like that, to where you can kind of confirm what you're seeing at the bedside with someone else, or potentially refute what you think you're hearing or seeing. So having that individual is really helpful. And so I'm so grateful for Pete Sullivan and Lynn Lorio at Oregon Health and Science University, who really showed me the way and showed me how powerful the physical exam can be. And you're going to come across that a lot, Arturo, where people will downplay the exam. And, I think it comes from, for a lot of reasons, but one is that it takes a lot of training and patience to learn the exam. And some people just don't, they don't have those skills. And so it's, almost a defense mechanism for them to downplay its importance because they don't have those skills. Another is that we're unfortunately limited by time as clinicians, and we have to see these patients in 15 minutes or less, and that doesn't allow for people to perform a proper physical exam. So for a lot of reasons, people will downplay it, but it's not, they like to cite these articles too, where the JVP was a coin flip, and if you look at these papers, well, who did the evaluation of the jugular venous pulse? It was medical students, residents, and no offense, but these are individuals who are very early on in their career and who don't have the necessary training. And so it's more those papers that showed that the JVP wasn't very accurate was more of an indictment of the individuals who did the evaluation than the test itself. For example, if you looked at CTA for sensitivity and specificity for pulmonary embolism, and I was the one doing the evaluation of the CTA, it would look like a horrible study because I'm not trained in that. So again, I would take those studies with a grain of salt, and I would respectfully ignore individuals who tell you that the exam is not worthwhile, because in my experience, it absolutely is. I can't tell you how many patients we've seen over the years that went undiagnosed because individuals didn't take the time to examine them, didn't have the time to examine them, or didn't have the skills to examine them properly. You're very welcome. And Joe, I can't tell how many people are still left in the chat or if there's still other questions.
There's still about 40 people left.
Okay. Well, if you guys have questions, feel free to ask. Share other stories. Well, you're gonna have to give me some direction there, Antonio, because I can share a lot of stories, but you'll have to tell me what you have in mind about physical exam. Okay, I'll tell you another story. So here's the thing: people will say, especially cardiologists, will say that and I've heard a cardiologist that I really respect say this, and he told a group of medical students that the exam is not worth doing anymore because everyone has an echocardiogram. And it really changed my perspective of that individual. Now, here's the thing: cardiologists may be in a position to where they can say that may be true for them, that by the time a patient comes to see a cardiologist, they probably already have a diagnosis, they probably already have an echocardiogram. But as a general internist, we're on the front lines where we're seeing undifferentiated patients. By the way, that group of medical students are also undifferentiated. So they may be emergency room physicians, they may be primary care physicians in the future, hospitalists, and they're seeing patients who do not have an echocardiogram. And so we absolutely need to be skilled in our exam in order to pick up abnormalities and to know when to order that echocardiogram. So that really bothered me to hear him say that. And then the other thing I would say is that even when the diagnosis is known, so a story that I like to share is I had a patient with mitral valve endocarditis who was admitted to the hospital, MRSA endocarditis of the mitral valve. And a few days into his hospitalization, when the diagnosis was already known, I was listening to his heart and I heard some scratchy sounds coming from his heart in a rhythm, in a kind of a triple cadence rhythm. And what I was hearing was a pericardial friction rub. So that clued me in that now there was involvement of this patient's pericardium. And after a few days, that scratchy sound became less and less, and then it disappeared. And at the same time, that patient started to develop hypotension and lightheadedness, and his heart sounds became a lot more distant. And so what do you think might have happened? Well, what happened was he developed a massive purulent pericardial effusion from the involvement of his pericardium with MRSA. And so as the visceral and parietal pericardium are separated now by fluid, you no longer hear those scratchy sounds and the pericardial friction rub goes away. And that's exactly what happened. Now, this is a story that I like to share because exams evolve. So the first point I'd like to make is that the pericardial friction rub can only be heard with the echocardiogram. There is no ultrasound or echocardiographic equivalent of a pericardial friction rub. That's number one. Number two, the exam
only with the
evolves
stethoscope.
over time. I'm sorry?
You said with the echocardiogram, you meant only with the stethoscope, right?
Only with the stethoscope can the pericardial friction rub be heard, not the echocardiogram. So there is no equivalent on echo of the pericardial friction rub. You can only hear that with the scope. And number two is that exams evolve. And so, we're not getting echocardiograms on these patients every single day that they're in the hospital. And so, if you were to rely only on your echo there, you would, first of all, have never even thought about pericardial involvement, nor would you have picked up the evolution there and the pericardial effusion that needed to be urgently drained. So there's a story for you, Antonio. Let's see. Any discussion on POCUS and supplementing the physical exam? Benji, I would say, yeah, listen to the recording because we did touch on that. You're quite welcome. Ignacio, you're very, very welcome. I hope so too. I'm glad you enjoyed the stories, Adam. These things do change. They do change. Patients may have an S3 one day and it may be an S4 the next day and it may be gone the day after that. Things change. There may be a friction rub one moment and an hour later it may be gone. I'm looking up at the top. I see Martin in Argentina. Martin, it's really good to see you. I see an icon of your face. I see Zavin. You guys have taught me a lot over the last months and years, and so I'm glad you guys made it in. I'll have to unmute you guys next time. I think we did like a universal mute thing, but we'll have to account for that next time because you guys have so much to share. Benji, this recording will be available sometime over the next couple of days.
We'll send out the link to everyone that registered to the email that you used to register within the next couple of days.
Well, from my standpoint, this was really fun to do. I didn't even know that Zoom or WebEx existed before, COVID happened. So I think this is something that we can adopt and do moving forward. I think this was really fun from my standpoint. It was really great to see some of you guys and gals, and the questions were great. Would love to be able to repeat this talk. Would love to be able to explore other categories in physical diagnosis, cardiac auscultation, other things of that nature. And so this was a lot of fun for us. So we enjoyed it just as much as you guys did.